Okay, today we're going to be talking about treating patients in the intensive care unit. ICU is probably the most intimidating setting that PTs, PTAs will work in um, consistently. There's a few others that might get a little bit dicey, but for sure there's high risk with these patients. They have lots of lines and tubes attached. Their medical conditions are such that they're needing close monitoring, so they're somewhat unstable. But we do still need to help get these people up and moving. The longer somebody stays laying flat on their back in bed, the worse things are going to get. So many body systems will start having problems. So pretty much as soon as we're able to, we'll get orders on a lot of these patients to start helping them either do exercises just to maintain a little bit of activity, depending on what they're hooked up to and what's going on with them, or actually trying to get them up out of bed, trying to go for walks in the room, work on simple ADLs, eating, brushing teeth, things like that, sitting up for periods of time, get them used to being upright. Um, and again, it is a, a tough environment in a lot of ways because they have so many lines and tubes attached, and many of them, if we pull them out accidentally, is either going to be very painful for the patient or very difficult for nurse or physician to reinsert some of those lines and tubes, or could potentially cause them to bleed out if we pull out an arterial line or something, or pass away if we pull out like their ventilator or something like that. So we're going to talk a little bit about just different conditions that will put people in the ICU, and then we'll kind of review some of the more common type of equipment that you'll encounter and kind of how to manage it. Um, this is definitely a setting that for those that end up doing hospital-based rotations, I would definitely encourage you to try and see some patients up there so you get at least some sense of how to manage those things in case you find yourself in that situation in the future. All right, so looking at this picture, this is not an uncommon amount of lines and tubes and equipment that you might see on a patient in the intensive care unit. This particular patient is not in their room, and I can tell that because the bed that they are on is more of a transport gurney. It has the very flat base piece to it, and then this single bed rail on the side. And also the mattress is not the type of mattress you would expect to see a patient on who has a lot of mobility issues. This is just a thin foam pad, and usually they're going to be on a specialty mattress that um, does a much better job of taking pressure off of their skin and preventing ulcerations. But let's talk a little bit about what we've got going on with this patient in here. So they've got restraints on their wrist. That's what this black line is, and it's tied off to the bed frame. So probably they're somewhat sedated. Maybe they're agitated. Maybe they're confused, but they're worried that that patient is likely to pull out some of those lines and tubes if they are not restrained in that way. We'll talk about restraints a little bit more next semester in therapeutic procedures one, but they are something that the physician has to order. They have to reissue that order every 24 hours, or else it lapses, and then we're no longer allowed to restrain those patients. Putting patients in restraints is tough, but sometimes necessary, depending on what they've got going on. And mostly, if it's we're worried that they're going to hurt themselves by pulling out lines and tubes, is the most common reason. Um, if we look over on the left, this biggest machine that's in there, that's a dialysis unit. And so you can see these different lines going over there, probably going up into the patient's jugular vein, I would guess, is probably where they have that hooked up. It's probably somebody that's only recently on dialysis. That's usually not the location that they do like chronic dialysis patients through. So probably somebody that went into renal failure acutely rather than having just a gradual degeneration of their condition. If they are a more well-established dialysis patient, they'll usually have what's called a shunt in their arm that basically allows them to hook everything up without having to get so many needle sticks all the time. So it's a kind of a semi-permanent little port that they can hook that up to. So while patients are on dialysis, I never really got anybody up and moving. The risk of detaching one of those lines while all their blood is being filtered is not worth doing things with them. So that's what that biggest device is. Um, Up top, we've got the monitor, and that's definitely something that you'll see in ICUs all the time. Pretty much any patient that's in ICU is going to be hooked up to a monitor like this. And you can't really see everything that's shown on there, but most often you're going to have an EKG tracing that you'll see. You'll see a pulse oximetry reading. You usually see blood pressure readings up there. Um, those are the most common. Sometimes you'll have temperature on there if they have an internal temperature probe. Um, so those are the most common things that are represented with all those different colored lines, just giving you an instant graphical display of that information, which is great when you're working with patients because it's often, pretty continuous. So when we're having this person do some activity, we get an instant readout of what's going on with their heart rate, how much work they're doing, and we know when we need to back off because we get that information really accurately and really, immediately. In it, if we're monitoring a different patient that's not hooked up to those type of equipment, then we have to kind of stop what we're doing, try and check all those values ourselves. Definitely a higher amount of error if we're checking those things manually or with less invasive type of setups than we'll see with an ICU. So this is, while they're tethered to these things through some hardwire lines, which makes moving around challenging, the data that you get from it can be very helpful. We can get it, we can walk in the room and just look up there and see what their last blood pressure reading was, know where that stands, see what their current heart rate is. So it's definitely a good thing to have. When we do have to get patients up and moving, depending on their condition, some of those lines can be detached. Usually that's something that you have to talk to the patient's nurse about, which ones they could remove to help you get them up and moving and potentially walking down the hall a little bit if they're able to. So that's a really key thing there. Um, we've got multiple IV pumps. So we've got one stand here with just a single pump, this blue pump right there, and then we have this other one that has three pumps hooked up to it. Um, Up on top, you see all these different bags. Most of these bags are the bigger bags are just going to be bags of saline, sometimes what's called lactated ringer solution. And they're going to use that to basically mix the actual medication. These smaller little containers that are over here on the left-hand side are little vials of whatever meds they're giving this person. And those would be being infused directly into a vein. With somebody like this that's hooked up to all this stuff, chances are he probably has a central line, he or she, that's going to go up into the subclavian vein. Um, you don't want to give lots and lots of different medications through a vein in somebody's arm for very long, especially if you're giving multiple medications like this person. A lot of times they might have a what's called a central line, so you'll have a where the subclavian vein is, they'll have a port coming out of there. And many times it'll have like three little separate tubes. So you can basically put different medications in each one depending on if they're can't interact and you don't want to put them through the exact same line all the time. Those three little ports will go into a common line, but it's more just where you're actually introducing the medicine into the line that goes into the patient. So that's what all those pumps are. They're good at going off and making lots of noise. Um, Most of the time, they're just telling you that either the medication is empty or that the line is occluded. That's one that we will often do when we're moving people around. If they're using their arm and the IV is in their arm, if they're cocking the wrist back to like push off the bed or hold a walker, that'll kind of put a kink into the IV line and will signal that occlusion. So we don't freak out if it alarms, just see what it's saying. Most of the time, if it's an occlusion, then you can have the person kind of straighten the wrist out or straighten whatever joint is kind of bending and potentially crimping down on the line. And then you can usually just silence the alarm and it will resume and be just fine. If it's empty, I just keep silencing it while I'm working with the patient, and then I'll let the nurse know as soon as I'm done. It's usually not that critical of a thing if their medication just runs out. If you notice bleeding from the IV line, then for sure you want to go ahead and get the nurse in there so they can manage that situation. But most of the time, the alarms on those IVs are not something to worry about. The monitor will often alarm too, and that one you probably need to pay a little bit more close attention to because that's actually monitoring the patient, not necessarily responding to monitoring the IV pump. So we want to know if their heart rate's shooting up too high or if it's stopping, or if their blood pressure is sky high or whatever the case might be. Um, Looking over on the other side, we've got another pump right here. Picture's a little bit blurry, but I'm pretty sure that's a feeding pump. This little bag up there is probably the bag that had the solution that they're putting through there. Usually a feeding pump is going to, the fluid that they put in there kind of looks like Ensure, kind of this milky white. And so it does have, carbs, proteins, and fats in it as well. And then that will usually unless the patient has a permanent opening into their stomach called a PEG tube, percutaneous epigastric tube, they're just going to have usually a feeding tube that goes through their nose. So it'll be Well, I've got one I'll show you in a few minutes. I'll turn on my camera and show you some of these things. Um, but it'll basically go up the nose, down the back of the throat, um, go past the epiglottis so it can stay in the esophagus, and then go all the way down into the stomach. And then it basically is just going to, they set the pump at a certain rate, and it just lets that feeding go into the patient's stomach directly. And so when somebody's unconscious, hooked up to a ventilator, they're not able to eat, swallow, we still need to feed them. And so that's the most common way that you'll see that done is with a feeding tube. Over on the far right is actually the ventilator machine. So this person is hooked up to a ventilator. You can't really see all the tubings, but these white or clearish looking tubing, it's usually kind of corrugated to give it some rigidity. Sometimes they'll be blue, but usually they're either white or like a light blue. And so those are basically pushing air into that patient's lung to help keep them breathe is what the ventilator is going to do. And you have different types of ventilators, some that are volume responsive, some that modify how much air the patient is given based on how independently they are breathing. Some of them are time driven, pressure driven, so they have different ways of setting them. I didn't usually manage much on those other than watching out for the lines and tubes. The lines and tubes on those are usually about 6 feet long or so. And you can see this kind of arm that sticks up on there and coming down, and those kind of hinge and can be used to kind of position the tubing where you want it to be. Many times it's not a super straight line. You'll get a little bit of a sag in the middle of the tubing, and sometimes condensation will collect there. And so we need to be aware of that because we don't want to lift the tube in such a way that the condensation inside it would then run right into the patient's lungs, and potentially, we don't want to dump fluid in their lungs. That could definitely lead to a pneumonia situation or something worse. So those are kind of the main things that you're seeing in that image. Hooked up to the wall, you can see some lines and tubes coming off of there. Pretty much all hospital rooms, and especially in ICU room, you're going to have lines for direct oxygen to be delivered, so you don't have to have any kind of tank or anything. You're going to have a suction line, so you can actually have a vacuum basically. So if you need to suction things out of their lungs, out of their oral cavity, things like that, you have that ability. So those are the most common things that you'll see coming out of there, just usually oxygen and suction, sometimes a few other things, gases that will come out. So there's a lot going on there. And then there's, when you try to get somebody out of bed, a lot of times you're trying to fit in a chair right next to all this equipment. And then you have to figure out, where do I need to put the chairs? Where do I need to put the IV pole? Are those lines going to move the correct way with me? Is anything going to get snagged here or there? So you have to be pretty creative and pretty cautious, and it's often more than a one-person deal. If one person is fully invested with helping the patient, we often need at least one other person just to kind of manage all the lines and tubes, and sometimes more. So this can be a bit of an ordeal. But if you're having to see patients up there, generally the nurses are very helpful. They don't have a lot of other patients, so they usually are willing to kind of jump in there and help. I'll bring aides with me if I have them available to help manage those things, or potentially grab the nurse's aide to help too. Again, those people in ICUs are usually pretty helpful compared to most of the other parts of the hospitals. I'm not saying that the other nursing staff isn't as helpful, but they're usually managing a lot more patients and have a lot more different things to tend to than the ICU nurse, who may only have one patient or two at most, is most common. All right. So a lot of these patients do have a lot going on. It's pretty rare that they only have one thing wrong with them. We see a lot of what are we call train wrecks. Just they've got diabetes, they just had a heart attack, they've had a mild stroke in the past, and they have an amputation, and they sleep with CPAP because they're obese, and you just never know. So a lot of those, when we have patients that have multiple diagnoses, then we kind of have to think back about all those different conditions, what sort of limitations they might put on the patient's ability to perform work, what sort of things might be, what sort of activities might be risky for us to do with them based on what they have going on. And so we do need to know all this pathology stuff that we've been learning about all this semester to be able to know what to do with these folks, and know what's safe, know what's not safe, know what could go wrong, thinking about what predictably could happen with this patient that has these different conditions, what's likely to give out on them, what's likely to start to deviate from normal. And so we do need to definitely be knowledgeable to work with these folks. We do want to keep really close tabs on all the data that is being displayed on the monitor. Um, a lot of what we're doing is basically trying to relay to physicians and other providers how taxing the activities that we do with these patients are. What sort of physiological response did we see in their heart rate and their blood pressure after we do exercise, after we tried to walk them? How much help are they needing getting in and out of bed? How far can they walk? Are they having to use a walker or a cane to assist themselves? Um, is it just a struggle to sit up on the edge of the bed? What do they complain about? Do they feel nauseous? Do they feel dizzy? All of those bits of information can be important in trying to help improve that patient's stability so that we can eventually discharge them to another setting, whether that's home, whether that's to a different part of the hospital with less intensive care, whether that's to a different facility that's going to manage this patient for another month or two while they continue their slow recovery. It really just depends on what they've got going on. These patients have lots and lots of lines and tubes. They are generally pretty sick folks. So we need to really be cautious and make sure that we don't transmit things to them. Many times they might have infectious conditions going on too. And so we also don't want to pick anything up from those patients. So gowns, gloves, masks, face shields, all those type of things are very common in ICU settings. I've worked in different hospitals that required you to gown up for every single ICU patient that you saw. Um, they have a much higher risk of developing nosocomial infections that are acquired in the facility than patients that are just on a normal part of the floor because they just don't. Again, they've got so many different lines and tubes going into their body that invite infectious organisms to get into their body, and then because they're so much more unstable and at risk of being unable to fight off infections very effectively, depending on what organ systems are complicated. Um, in general, in a hospital setting, therapy is kind of considered secondary. Now, on an orthopedic floor, sometimes our need to work with a patient can supersede what the nurse needs to do with that patient because us assessing their mobility and getting them moving after knee replacement, hip replacement is a super important part of their care. But for most of the other patients in the hospital, if we're in the middle of working with the patient and another provider comes in there, it's very common for us to get interrupted. They need to start this medication on this certain schedule. Otherwise, they're going to be behind, and the next shift won't be able to give it correctly. They need to come down and get picked up go down to get an MRI or a CT scan or go to do some other procedure. So it can be a little bit of a little chaotic working in that environment in the hospital in general. So you have to be flexible. You can't get too worked up about things if people take your patient from you and you have to go find another patient to work with. But that's also kind of the beauty of it. You don't have a set schedule most of the time. You're just trying to see patients when they're available and do what you can with them and then move on to the next one and just try and see everybody on your schedule every day and however often we're supposed to see them. That last little point is pretty important too. We do have to move a lot of furniture around, IV poles around, unplug stuff, shift things here and there when we're trying to get these people up and moving. And it is super important that we remember which things we unplug, which things need to be plugged back in, where they need to go, making sure that we leave things where the patient is going to be able to reach them if they need to call for help, if they need to get a drink of water. So we really have to be conscious of, if we're going to get the patient out of bed, leave them sitting up for an hour, for example, we need to make sure they have everything that they need, including the call bell, most importantly, right within reach. So that way, if they start feeling bad or if they just need help with something and they need to go to the bathroom, they're able to immediately get some help in there with that. And then nursing staff will certainly appreciate it if we rearrange things the way that we found them. Think about Johnny is watching you. If you're working in the hospital and you have to do it, put everything just right back where it was, or else he's not going to be a happy camper. We want to stay on nursing's good side, so they'll help us when we need help. And it usually goes both ways. So if we have shown in the past that we've worked well with this nurse and we've been considerate of their needs and the patient's needs, that nurse is much more likely to jump in and help us when we ask them. And so it is a very cooperative environment when it's working well. You'd want to be familiar with some of these lab values. Some of these aren't necessarily ICU based, like to know somebody's cholesterol level. That's really not that critical of an ICU value. Their blood sugar level, the PCO2 and PO2, those are arterial blood gas values. So they're sampling a bit of the patient's blood to try and get some idea of how oxygenated it is and how much waste is being built up in their system. And they use arterial blood because we want to know after that blood's gone to the lungs and then come back to the heart and then it's getting pumped out in the body, were we able to get rid of the CO2 that's being produced by the body as the persons were breathing out through their lungs, and were we able to reoxygenate the blood so that when it's going to the rest of the body, it has something that the patient needs, that oxygen is loading correctly. So those are values that they will track. pH, super critical for so many different functions in the body. We want that to be in that really tight window, right around 7.4. Um, the H and H values, hematocrit and hemoglobin. The hematocrit is the formed elements in the blood, what percentage of the blood sample is plasma versus what is more solid stuff. And then the hemoglobin is definitely related to that hematocrit because the hemoglobin is basically giving us a count of how much hemoglobin there is on the red blood cells. The red blood cells are kind of the key component that makes up the hematocrit. And so we see some differences between men and women, and that's mostly due to women having a menstrual cycle and men not, um, where women tend to be just a little bit lower. And that those two values represent our oxygen carrying capacity, really. And so when they're low, then you should expect your patient to get winded and fatigued much more quickly than if those numbers are normal. And patients that have been in traumatic accidents, patients that have had surgeries, they're often going to have lower H and H's because they will have lost some of the blood during those procedures or potentially during that accident. The ESR, often called just the SED rate, that's a sign of inflammation in the body, and so that just gives the physician some idea of what might be going on metabolically as far as the patient's condition is concerned, if they're fighting an infection, if they're dealing with trauma. So that's a pretty important value that they'll often look at. And then the white blood cell count, certainly important if we're worried about a patient having infection, a pneumonia patient, MRSA infection, any number of types of infection would be important to track that value. All right, so let's talk about some equipment. So you can see this procession of folks helping this woman walk in the hospital, and she's on a ventilator. You can see the thicker kind of ventilation tubing right there. It looks like she has a tracheostomy cuff probably underneath that cervical collar, and they're probably just using that cervical collar to kind of stabilize the lines coming out. These look to me like they must be um, dialysis tubing, which again, that's something I never really did, was to walk a patient while their dialysis treatment was going on. But I think looking at this apparatus, that probably is the dialysis unit that they're trailing. You can see this cylinder right here. That's a portable oxygen tank. And so they're having to drag that along as well because that we need to basically supplement the ventilator with that oxygen. Um, this one doesn't appear to have a little rolling cart to it, which is usually what you'd want to do with an oxygen tank, so you can just kind of trail it along. It works a lot better to pull it behind you than to try and push it in front of you. Steering one in front of you, it just doesn't work. It's kind of like trying to drive a car with a trailer on it. When you try to back that trailer up, it gets kind of crazy. That's kind of how it is steering an oxygen tank when you're trying to push it in front of you. It's going to do a lot better if you just turn it around, hold it behind you, and let it follow you when you do that. So she's got a gate belt on. She's got probably this reddish kind of, it's probably like Coban, that stretchy kind of overwrap that we'll use on bandages sometime, probably to secure all of her different IV lines would be my guess. Um, but it does take a village to walk somebody like this when you've got all these different lines and tubes hooked up. So let's talk about some of these lines. I'll probably just scroll through the individual slides because we've got some on all those, and then I'll switch on my camera because I have some of these devices to show you so you can kind of get some idea of what they look like and kind of how they work. So arterial lines are just what they say. They're an IV line. It's similar to an IV line. The V in IV means vein. So these are usually called art lines is the most common abbreviation that I've heard them called. And they do go directly into the patient's artery. They're mostly done so that we can monitor things like that those arterial blood gases, the PCO2 and the PO2. We need to get that from an artery, and so they'll often leave those in just to pull those samples out. The other really common thing that they will do is they're going to be hooked up to a sensor that internally monitors their blood pressure. So we get a much more accurate and instantaneous readout on how their blood pressure values are changing. Um, in general, you need to be ultra cautious around arterial lines because if we pull one of those out, that patient's going to have a pumper. It's going to be bleeding out a lot. Every time the heart beats, you're going to see this spurt of blood coming out. So we always need to know if a patient has that. We don't usually, I learned to never really do a lot of exercise with the limb that has the arterial line in it. Most commonly, you'll see them at the wrist or in the femoral artery up in the groin. If they're in the femoral artery, I would do maybe like ankle pumps, but I wouldn't do like heel slides or anything with hip abduction on that particular leg. Just the risk of dislodging that is not worth the extra bit of activity that that patient's going to get. So we always need to be super aware of that arterial line. As far as how to tell that apart from an IV line, um, I don't have either of those type of lines here. I have another line that I'll pull out in a minute to show you for a different component. But IV lines are flexible. You can pinch them and they'll kind of squeeze because they're a low pressure system. Our veins are much lower pressure than our arteries. An arterial line is going to be clear plastic. It's going to be rigid though. You can pinch on it and it's not really going to depress. We don't want it to depress. We want it to stay rigid so that we don't interfere with that pressure reading in the blood. And it gets transferred accurately. So if you pinch it and it doesn't budge, it's probably an arterial line. If you pinch it and it kind of flexes when you pinch it, then that's going to be an IV line. So that's the quick and easy way to kind of differentiate between the two. But you'd be reading your chart anyways before going to see this patient to see if they have that arterial line, or potentially talking to the nurse about it and what you need to watch out for. So EKG monitors. We talked about EKG earlier in the semester when we went over the heart. And again, a lot of patients in the ICU are going to be having a continuous ECG monitor. Sometimes, depending on their condition, we'll be allowed to unhook it, depending on what's going on with them. Not generally with a cardiac patient, but with a lot of other patient types. You can go ahead and get clearance from the nurse or physician to unhook them, so you can get up, move around, walk if they can, come back, and then rehook everything back up. Sometimes you still want to get that patient up, and then you can use a portable unit to hook up, and usually it ends up being a crash cart. So we'll have a crash cart that has for defibrillating somebody, and it has an EKG monitor on that, and so we'll just end up plugging the wires into that device instead of into the wall, where they can get the readout on the screen in the room. And then when you walk the patient, then you just basically have to trail along with them with the crash cart. So again, another reason why you often need multiple people to kind of manage these folks. One person to guard the patient, keep them safe, one person to drag all the equipment along. Sometimes you need another person to kind of monitor things, or you might need two people to kind of help drag stuff along or to help assist the patient. So we're mostly looking for big changes. We should expect the heart rate to go up when we increase activity with the patient, but there are certain patients where we might have specific instruction not to push the heart rate too high, especially with some of those cardiac patients. Might be 20 beats above the resting, might be no higher than 100. So we do have to keep close tabs on that and understand when it's getting too high and when that might be putting too much stress on the patient. This picture shows the person with set up for like a 12 lead EKG. Most of the time in the hospital, you're only going to see like 4 electrodes. They'll usually do what's called a 3 lead, and you'll have one wire that's a ground wire. So you won't often see quite as many of these electrodes. An ICP monitor. The hospitals that I worked with were mostly smaller community hospitals, and we really didn't handle people that had brain injuries. They'd usually send those to a trauma center. So I didn't really get much experience working with these, but similar to an arterial line in the vascular system, an intracranial pressure monitor is used to just measure how much pressure there is in the brain. And we don't want that to get too high because then that can compress the neurons themselves and cause some complications. So you'll see these used after people have had like skull fractures, other types of traumatic head injuries. If they've had a brain surgery, had a tumor removal, or something like that, then you might see these in there. Again, obviously something we don't want to pull out. These are things that we would probably have restrictions on how much activity we could do with that patient. The pressure in that would change dramatically if we go from supine to sitting because of gravity, but pull that cerebrospinal fluid kind of down into the spinal cord more. So we do have to kind of be super aware of um, how high that's allowed to go, how low that needs to go, and be cautious when we're moving those patients around. And obviously, we don't want to pull that out. That would be a big bad thing. All right, then we have IV lines. So IV lines is going to be probably the most common thing that you'll see in a hospital setting. Almost every patient in the hospital has an IV at some point. Sometimes they're temporary, sometimes they're unhooked, and then they just have the port that's still in the vein waiting to be hooked up for whenever their next dose is. And so when you have a patient that doesn't have a medication actively running and you can find your nurse, then they're usually more than willing to unhook it so you can get up and move the patient and not have to worry about dragging that IV pole along with you. If you can't find the nurse or you're really busy and you don't want to wait for the nurse, then even if it's not running, a lot of times I would just take it and go. You can have some pretty crazy chaotic days, and if you're always waiting for the nurse to come do something that's not that critical, um, you're going to lose a lot of time and efficiency in your day. So a lot of times you're just like, yeah, it would be great to unhook this, but I don't know where she is, he is, so I'm not going to worry about it. We're just going to take it and go. Um, but we definitely want to watch out for the lines, make sure we know where they are, um, make sure we're not putting too much tension on that when the patient's getting up and moving, so that we don't pull that out. I've definitely had more than a few IVs come out. Sometimes they just come out over time. They're usually taped down. Sometimes the tape will get a little bit wet and less sticky, and it makes it pretty easy for them to slide out. And they usually have to change them every few days, anyways, because they start to wear the vein out, basically. Um, but really, really common thing for patients to have. You'll see a lot of patients that are on some sort of compression, either some type of stocking. The most common one that you'll see is called a TED hose. It's white most often, and you can either have a knee-high version like this person has, or you can have a thigh-high version. And so a lot of patients that are post-operative will have those in place. A lot of times they'll use them just on anybody that's not really getting up and out of bed much. They're a real struggle to put on if you're putting on compression socks on yourself, and they're a lot harder to put on somebody else, especially if they're having pain and you're trying to put it on a leg that had surgery. You're trying to somebody had a hip fracture, let's say, and you're trying to put on a thigh high TED hose on them. That's a challenge because it's a lot of pressure. They're not easy to put on or take off. The other type that you'll see a lot is down below, and that setup right there is usually just called an SCD, sequential compression device. And so you can see the person's lower legs. There's a bladder that runs kind of lengthwise along the back of their calf, and then this little pump unit on the foot of the bed is going to alternate and basically kind of inflate one leg's bladder and then deflate it and inflate the other leg's bladder. I think you can probably set it where it does both at once, and some patients prefer that. Um, some patients love these things. Oh yeah, it feels like a massage. Other people hate it because it's like somebody's always squeezing my leg, um, and hard to sleep if you got somebody constantly like puffing up this tight bladder around your calf to squeeze your leg. And these are meant to prevent both of these techniques. The stockings as well as the pumps are meant to limit the person's risk of developing a DVT, a deep vein thrombosis. There's another type that you'll see somewhat often that is a little bit smaller. It just goes around the ball of the foot, and that usually has a Velcro strap that loops around the heel and then kind of crosses over onto the dorsum of the foot. But the idea is the same. If you were putting pressure against the ball of the foot, that's kind of where the capillary bed is, but the end of the line for circulation. And so if we can squeeze that foot, kind of milk that blood out, then it's going to also help with that venous return. If you remember on our veins, we need that muscle pump normally to help facilitate kind of squeezing the blood from the lower leg and getting it back into the central circulation. And so when people are laying on their, laying in bed all day long, recovering from surgeries or illnesses, um, these things basically are just taking the place of the muscle pump action to try and minimize swelling and minimize the risk of clots. Um, Always remember, if you've taken them off to get somebody up and move or walk, then put them back on after the fact. There's a little, you can see how the tubing coming out of the machine is orange, and then the tubing coming off the bottom of this little leg sleeve is clear. There's going to be a little connector, and it's usually just you push on a little button, and it basically has some sort of ring mechanism that loosens the tension, and you can just pull the two pieces apart to detach them. Um, I've seen people walk patients with these on, but they tend to kind of start to slide down the legs, and then that little extra tube is probably about 6 inches long, and so you got that thing dragging on the ground. I think it's far better to just take them all the way off and just remember to put them back on when you get the patient back in bed or back sitting up in the chair, and then don't forget to turn the pump back on. All right, oxygen. Next to an IV, that's the second most common thing that you're going to probably see on patients in the hospital. Pretty much any patient that has surgery, they're going to put them on oxygen at least for the first day or so after surgery. Many other patients will be on oxygen a long time. You look at heart attack patients and stroke patients and things like that. So not uncommon at all to see that. Up in the top, they've got a little device called a pulse oximeter. I forgot to bring one home, or I'd show that to you here in a bit. We have a number of these. We'll use those in lab over the next couple of semesters to try and help you see how to assess people. And it gives you a readout of two different things. The top number on this one is the oxygen saturation level. So it uses a infrared light basically that shines through the fingernail into the capillary beds there and can sense that how loaded up with oxygen hemoglobin is on the red blood cells. And then the second number is the pulse rate or the heart rate. And you'll see you have a little LED readout on most of these that's going to go up and down each time the heart beats, and that's how you know you're getting a good consistent readout on the device. If a patient's hands are really cold or they have really bad circulation, these don't work very well. But if they have decent circulation, then they're usually a pretty good way to keep tabs on how hard the patient's working and if their oxygen level's starting to crash. This gentleman in the picture has what's called a nasal cannula. And it's going to have two prongs that go one into each nostril that kind of curve a little bit. And you want those prongs to kind of curve backwards. Our nasal passageways curve backwards once we get inside the nostrils. So that's how we need those things to face. If you're putting this on a patient or helping a patient adjust it, you want to make sure those prongs go in the correct way first, then bring it over the top of their ears. And then there's a little like bolo tie kind of slide that you put down there to kind of tension it up and keep it in place. You never want to put the thing entirely around the person's neck and then cinch it down. You always want everything to be in front. So if it gets tugged, it's not going to choke the person. It's just going to pull off of their ear, which is not that big a deal. You will see sometimes patients will get pressure injury on the top of their ear from this tubing, and they make little pads that you can put up there sometimes. They usually look like the foam insulation that you might put on a pipe outside your house, only smaller. But they basically just encircle the tubing and provide a little bit of cushion and padding there to decrease that risk. There's the portable oxygen tank with the little cart. So that's the preferred way. That way it rolls. And these are the ones that I said y'all want them to kind of trail behind you. Up top, you've got a little valve mechanism. And so it's going to screw in. You have to have a special kind of little key thing to take the valve on and off of a tank and unlock the tank so that the air can flow. Kind of similar to like a propane tank if you have that hooked up to your barbecue or something like that. You're going to have a gauge, that little black dial, and then you're usually going to have something that spins on the end to adjust that. And usually you adjust these in liters. The lowest flow is like a half a liter, which is pretty useless. It's not really going to do that much for the patient. And then it just goes 1 liter, 2 liter, 3 liter, 4 liter, 5 liter, 6 liter. With most nasal cannulas, 6 liters the highest you can go. They do have some newer ones called Salter nasal cannulas that are a little bit bigger bore, and you can go higher on those. Once you get up above about 2 liters a minute, which is the most common setting that they'll use, they'll start putting a little humidifier on there, on the wall unit anyways. If we're pumping in 100% oxygen at 4 liters, 5 liters, it's very drying to nasal passages and can lead to nosebleeds and things like that. So we'll usually have a little, um, it's usually kind of a little square kind of box type thing that kind of screws in line. So the water, the air coming out of the wall oxygen port will kind of bubble through the water that's inside of that little container and humidify the air so that way it is not quite as drying to the patient. Most oxygen tubes are 6 feet long, um, so not that long. When we start getting patients up, we can't really do much if they're hooked up to the wall other than kind of walk around the bed. I think the next one up goes to maybe like 15 feet, and then you can usually get 25 or 50-foot ones. When we have patients that are able to get up in their room independently and get over to the bathroom and back to their bed, then we're usually looking at more like that 25 or 50-foot one. But we have to watch out for them tripping on it, so we kind of need to be aware of that too. So those are different options for oxygen. Um, Oxygen is considered a drug, so it is not up to us to change their settings typically. Sometimes you'll work with a patient and the physician might want you to titrate the oxygen level to keep their saturation at a certain mark. So if we had them at 2 liters and they were like, keep them at 2 liters or keep them above 90% saturation. So you have the person on 2 liters, you're starting to walk along with them. They get 50 feet outside the room and you look and they're at 91% saturation. And then before you know it, they're at 88. Well, that's a situation for titrating it to keep it above 90. Then we click it up to 3 liters a minute, let the patient recover a little bit, see if we can bounce that O2 sat back above 90, and then we could kind of keep going. And then once we got them back to the room, we'd want to kind of let them recover a little bit and then probably dial that oxygen back down to the 2 liters a minute as long as that O2 sat was staying above 90 where they wanted it. So those are pretty common things that you'll might be asked to do in an inpatient setting with the oxygen. Sometimes you'll have nurses that'll be like, "Oh, you can just take the oxygen off and go walk in. That's fine." I'm like, if they need oxygen in bed, they need it more when they're walking. So I never really tended to do that much. I would go ahead and find my tank and bring the tank, unless, like I say, sometimes they'll say specifically, take the patient off oxygen, do your therapy with them, and let me know how their oxygen's holding while they're being active. And so that's a case where we would take it off. But I was taught, and I firmly believe that if they think the patient needs it when they're laying down in bed, then I'm going to use it when they're walking or getting up and doing exercises. Just kind of common sense. All right, suctioning devices. I think I'll just run through everything and then I'll kind of go through these different devices for you. I think that's going to be easier than trying to flip my camera back on and off. So suctioning, um, you'll use, most patients on ventilators will need suctioning. They're not able to get a really forceful cough, and so they need to suction their secretions out of their lungs, out of their throat. So it's pretty nasty. Basically sucking their sputum, their phlegm out of their lungs, and it's kind of noisy. Most of the time, the patient feels so much better after you do it, though. They can breathe a lot easier, and will definitely feel a lot better. And you can sometimes you can hear just the phlegm gurgling around in their lungs. It's pretty gross. It's like, yeah, go ahead and do that. I wouldn't do that much suctioning. Usually, I would let the nurse or the respiratory therapist do it. I certainly suction some patients, and sometimes you'll have where it's not a patient that has a trach, that's a different type of suctioning technique. Sometimes you'll have just a suction, what they call a yonker. It's kind of like a little plastic wand that they can just kind of like spit in or cough up in, and it'll just suck it away instead of having to go through a bunch of tissues. But that's usually kind of patient controlled, and so that's a little bit easier to just give that to them. But when they're hooked up to a vent, then you have a small little tube that's going to go down through the opening where the tracheostomy is, and then go down into their airways, and then they'll try and sometimes direct it to the right and left kind of main bronchi. You won't really go much deeper than that in most cases. You start poking around in there, you can cause some problems. So here's a little video clip because I know everybody wants to hear that suction.
Okay, Everybody's heard us talking about direct suctioning. If Margaret has a plug, you take this, it's already cleaned with alcohol, disconnect, put it straight up against the trach. You can hear the suction generate it. Let go. Suction. Good. And we're done. It's much quicker and
You guys got off light. That's a pretty clean one, pretty easy one. Sometimes it's a much nastier sounding. When I was a student, one of my first full-time clinical instructors, I guess it was my second one. She was she hated phlegm, and she hated hearing people cough and having phlegm and coughing up sputum. And my first day, we were going through orientation. She was kind of setting the stage for how things were going to go on the rotation. And she's like, I got to let you know, I hate phlegm. It grosses me out, makes me feel like I'm going to throw up. So if at any point we're working with a patient and they start coughing, don't be surprised if I bail and leave the room. And I was like, okay. I didn't really think much about it. About 3 weeks, 4 weeks later, I'm still doing my rotation, and we had that exact thing happen. We were getting up this guy that had a MRSA infection. He was really stiff, kind of older guy, and sure enough, he started hacking and coughing, and she bailed on me. And I was like, "What do you do?" So I had to kind of deal with the patient, get him squared away, get him settled back down, and I came out, and she's like, "I'm sorry, I was just about to throw up. I had to leave." I was like, "All right." Well. So even experienced people suctioning and phlegm can gross certain people. Not me. All right, so there's ventilators. Kind of talked about those a little bit at the start. In the bottom picture, that's not a ventilator, that's a BiPAP or CPAP machine. People that have sleep apnea will commonly use a device kind of that way. So that's, and sometimes you'll see patients in the hospital that use that CPAP at home and they'll be hooked up to it in the hospital. Um, the person above has a permanent tracheostomy, and so we have what's called this little cuff essentially, and that creates a little attachment point for the ventilator tubing to basically attach into that person's throat and help drive the air in and out of the lungs. They'll do the surgical procedure when they think it's going to need to be permanent or semi-permanent. You don't want to have a tube down your throat for very long. So this is a cleaner, easier way, a lot easier to move around with this device as well. And sometimes patients can tolerate being unhooked from the ventilator for a period of time um, when they get to this stage. And ultimately, a lot of times you can get these people weaned off of the ventilator, but um, it just kind of depends on what they've got going on. Most of the time, if somebody just has an endotracheal tube down their throat, I've got a couple samples of that I'll show you here in a few minutes. Um, we try not to really move them around a ton. We'll sit them up on the edge of the bed, get them out of bed maybe, but don't really walk very far. Um, I have walked a few people with ET tubes in, but most of the time, if you're going to walk somebody on the ventilator, you hope it's this type where they have a more permanent passageway. Um, that tube is pretty big in their throat and pretty uncomfortable. Um, a lot of times patients on a ventilator will just be given medication to sedate them so they don't fight it. That's the more common scenario on a vent. I've definitely had a lot of patients that were awake and alert on the vent, but that's less common than having the person hooked up and not sedated. The sedation just calms them down and obviously limits what we can do. We're kind of limited to just doing like passive range of motion type stuff when people are sedated, but when they're awake, then we can have them follow commands, have them try and do the exercise themselves, help sit up, help stand up, whatever else we can get away with. So drains are another pretty common thing. Um, this top picture is a chest tube. I'll show you a chest tube here in a bit. I've got a sample of that. So this is sutured into the person's chest, in between the ribs, basically wherever the hole was. I think it's usually where they try and go in if they developed a pneumothorax and they developed a collapsed lung, that kind of cases. So that'll stay in. There's a device that's on the other end of it that I'll show you. Um, and so that's used to help the lung gradually reinflate itself and seal off the leak area so that they can get the tube out of there at some point. But oftentimes that tube will stay in a few days, depending on the type of site that they have it in. But it's usually not that long. A couple days usually takes care of it. Um, Over here, we've got what's called a JP drain on this child. And these are kind of the most common post-surgical drain that you'll see. You've got a piece of tubing that's going to go into the actual incisional opening where that person's injury is, and it inserts down in there a little bit. So when they cut something out or cut tissue, you're going to have some residual bleeding, and you don't really want that big cavity of blood to kind of fill up. So they use these devices to kind of gradually pull some of that blood out as it's sealing itself off so that we can, minimize how much hematoma there is there. And so these are just suction devices. They're you squeeze them to get all the air out, and then you plug a little cap on it, and then it just is going to gradually kind of the flexibility of the plastic of that little bulb area will kind of want to re-inflate itself, and that creates this vacuum kind of draw that pulls that fluid out of there. Um, you can certainly get people up and move with these. They usually have another little kind of plastic ring that comes off of it that you can use to attach the drain itself to the patient's gown through either like a safety pin or tape it on or some other way to get it to adhere on there. Sometimes it has a built-in little plastic clip that can be used to clip it onto the patient's clothing so that it's not putting tension where the tubing is going into the wound. That's what we want to stay away from. We want to pin the bulb to take the weight of the bulb so it's supported, so that way there's nothing tugging on the tube and that might pull it out. So this particular type is called a JP drain for Jackson Pratt. I guess those were the two people that came up with that idea. You'll see some other types too. I've got a couple different drain types that I'll show you. Foley catheter. Urinary catheter is kind of the correct name, but almost everybody calls it a Foley. That's kind of the first brand, I think, that came up with this type of setup, and so that's where it's kind of like calling it tissue a Kleenex. Foley was just the first brand. This one isn't a Foley brand, but it's still called a Foley. So that urine looks really dark. That person's too dehydrated. It should be significantly lighter. Sometimes you'll have what's called a leg bag, and that's what this person has right there. That's more for somebody that's getting out and about in the community, but has um, an external port for their bladder for whatever reason. Maybe they have bladder cancer, maybe they have some other issue and they don't have the bladder, and so we need a storage vessel for them. The other type, this is the most common one that you'll see in the center there, big bag like that. It'll hold probably like 2 to 3 liters. It'll hold a lot of pee. You've got a valve on the bottom. They have a few different types to drain it as it gets full. Oftentimes, patients are tracked for their I's and O's in the hospital, their input and their output. So if we decide to drain this, which I've done many times, you don't want to carry around 3 liters of pee if you don't have to. It's fairly heavy and has the potential to leak and that kind of stuff. So it's easier to just drain it. But if somebody is having their I's and O's tracked and we drain it, we need to chart it and make sure that the nurse knows, the CNA knows. Sometimes they'll just have a piece of paper on the patient's room somewhere where they're tracking it. And if that's the case, then we can just put in 2 liters that we took off of it or whatever it was. It's going to have a little hook up top, and that little hook is usually going to be on the bed frame somewhere. We can hook it to our walker. I put it to my pocket if I needed to kind of put it somewhere. If you're dragging along an IV pole, you can kind of coil up the plug wires and loop it through there and hook it on there. The most important thing to not do with a Foley catheter is to not lift it above the patient's bladder, above the patient where it's coming out of the patient's body. We don't want it to backflow and create kind of this siphon effect where the urine that was just in that bag now goes back into their bladder. So that's the big no-no. If we're getting patients up, we always want to kind of keep it as low as we can. As we're passing it over, say we're bringing it from one side of the bed to the other, you don't want to just pick it up and lift it, 3 feet over the bed to move it over. The lower you can keep it, the better when it comes to that. Over here, we've got this connection to just kind of help take some of the tension off of the insertion point. So this is probably a gentleman's leg, it looks like. and so that it's going through this loop, and the band is kind of helping keep the tubing from being tugged as much. So that this kind of beige or yellow looking tubing is actually the tubing that goes into the person's bladder through their urethra. And then the white clear tubing is the one that's going to lead into the bag that collects it all itself. Very common. O2, IV lines, Foley catheters, those are just almost, there's a lot of patients that have all three of those things that we have to manage and deal with. So down below, it kind of shows you how they work. They usually the nurse will, if they're going to put somebody on a Foley catheter, they'll insert it up through their urethra, and then they have a little syringe that there's a port on the tubing that they can basically inject air into, and the air will inflate the end of the tubing, which is like a little balloon mechanism. And then you have a little slit in the tip that allows the urine to drain back in there. But that little balloon makes it hard to pull that thing out. You can see the mismatch between the size of the urethra and the size of that balloon. I've had multiple patients that have actually pulled that balloon out. They're confused. They don't know what's going on. They just know they got this tube coming out of them, but they don't want, and they start yanking, and that's a lot of extra force dragging along that urethra that's pretty small, so they can definitely damage themselves when they do it. But I've seen more than a few that have done that. So we have to be really cognizant of that line as well. Um, it's much harder to pull out than an IV line, but the patient will let you know if you have forgotten, and you might have it hooked onto this patient's chair while they're out of bed, and then you're going to get them back in bed, and you didn't notice that it was hooked on there, and before you know it, it's like, what's pulling on me? And you're like, oh, sorry. Or you get the patient up to walk, and it's still hooked onto the bed frame, and you didn't put it on the walker, and they start going, and they get about 4 feet away from the bed, and then doing, yeah. So don't do that. You will if you work in the setting where people have it. You'll do it at some point, but try to avoid it. All right. So let's talk about different. Well, let's go through the equipment. Let me stop this, and then we'll talk about why patients might be. All right. So let's start with this is about how big and kind of the flexibility that you would see with an IV line. So you can see when I pinch on it, it kind of gives a little bit, and it's about that big around diameter. This is actually from a feeding pump. So this is the bag for a feeding tube. Kangaroo is probably the most common brand that I've ever seen. So they'll just open it up, pour the, looks like Ensure in there, essentially, cap it off, and then you got this little dial right here that is how they adjust the drip rate. So they can kind of spin that down or spin that up a little bit, and that's going to pinch down and occlude the tubing a little bit or open it wide open. So they're going to have it set for a certain drip. So it's going to give them a certain amount of nutrition per minute, per hour, whatever it's set for. And then at the end, you're going to have something like this. So this would be the attachment if somebody had an external peg tube. So they'd have a little port that you would basically insert that into and jam it in there to secure it. If this is going to be used through an NG tube, then you wouldn't have this type of thing on there. But this size tubing would essentially go up the person's nose, down their throat, and deliver nutrition to their stomach directly. So that's a feeding tube. And again, kind of how that's going to work. Here is a little cuff that a patient with a ventilator would use. So they'd have that over their head. You'd tension up the strap to basically keep that where their tracheostomy is. We wouldn't use that with somebody that has actually the ET tube. You have basically a secure attachment for that, but this is for somebody that has like a permanent port that had surgery to put that in. And so this tubing is probably like the standard 6-foot tubing, and you're going to have just this end like this, and coming out of the wall or coming off of an oxygen tank, um, you're usually going to have something like this. And so they usually call this the nipple end. And so you're just going to basically jam those two pieces together to secure it and pull on it. So you don't want to jam it in there pretty tight so it doesn't come detached if you want it. Sometimes if you're stringing together multiple pieces of oxygen tubing, you'll have a little plastic connector piece that has a little thing that jams on either way, and so you can just jam them together, and then you can get 12 feet or 20 feet, however long you need with that. So that's a ventilation cuff, basically. Um, you might also have patients that are on a mask for oxygen, so they'll have it hooked up like this. Sometimes you'll have little things that you can cap on the sides so that the air doesn't escape as well. And so these are called rebreather or non-rebreather masks, depending on whether these things are closed or not. And they can often be used to deliver nebulizer treatments. So the respiratory therapist will come along, detach it, put the medication in there, screw it back on, and then crank up the flow so it will kind of bubble and aerosolize it, and then the patient can breathe that in to get whatever medication they're taking. Usually something to like thin their secretions or to open their airways or something like that. So different types of oxygen tubing. Um, Here is a suction tube. So it's inside this little plastic sleeve, and you can basically push it out of the sleeve, and it's got little holes in the tip that they would be using to suck up the phlegm as well as through the very end of the opening. So this is kind of what you'll see when patients are hooked up to a ventilator, because you don't want to handle this tubing directly and then jam it down their throat. So they'd attach this to the outside opening, kind of like in the video, and then basically you kind of telescope this tube out of the plastic sleeve to feed it down, and then hit the button to suck all the phlegm out, and then they can just pull it back out and set that to the side, and it's less contaminated than it would be otherwise. So that's a little suction tube. Um, we've got an NG tube. So this is a little different. This is called a nasogastric tube. It's also going to go down the patient's throat, but unlike the feeding tube, you're trying to suck stuff out of their stomach. We don't want, these are used with patients who they don't want stuff to pass through the digestive system. So they've just they had colon cancer, let's say, and they had a chunk of their intestine taken out, and they don't want anything to go through their stomach that's then going to go through their intestine for a period of time. Sometimes they'll use them with patients that have just extreme nausea, so they can just keep sucking things out. But you can't really feed somebody while this is in there. So this is a pretty big bore. It's going to go through your nostril, through the back of the throat, and basically down into their stomach to suck the stomach contents out. So nasogastric tube is what NG stands for. They'll often use a little Band-Aid that's custom for that. So that's for securing NG tubes. Basically, I guess I could open the pack. We've had them for a while. Haven't opened them, so I might as well be that guy. So they're shaped like this. You're going to basically end up probably taping it across the bridge of the nose that way. And then this piece is going to tape down onto the tubing itself. And so the patient will have that set up to kind of hold the tubing as deep down their throat as it needs to be for that. This end is going to be hooked up into the wall suction. And so you're going to, it would be unplugged. There'd be another tube coming in there that then is hooked into the vacuum setup on the wall that they can crank it up so that they can suck the stuff out of the person's gut, and then it gets put into this nice little canister. People that have a bleeding ulcer might have it. People that have, there's a lot of different things they use these for. When we're going to get somebody up and move, try and walk them, for instance, we'll unhook them from the wall suction, and then we'll plug this cap up like that so we don't have leakage. And then this thing can usually just go down. There's usually a pocket on the front of most gowns in the hospital, and so that can just go into the pocket, so it's not just dangling and getting in the way where it might catch on something. So NG tube, nasogastric tube. Here is the JP drain that we showed, and so this would be the end that's in the patient's wound, and you can see all those little perforations in it. And they would cut this depending on how, they might not need that whole length of it. It's about, I don't know, probably 8 inches long or so. So you don't necessarily need that much all the time, but that's what's essentially inside the wound, and then they'll have it like between the sutures on the surgical incision, so that when they feel the time is right, they can just slide it right out, and they often don't even have to put another stitch in. But the rest of this will come out, and there's the bulb itself. Here's the little plastic clip that I mentioned that some of them come with that can be used to like clip it onto their clothing so it doesn't go anywhere. So you just can do that with it. And then to, might help if I unclipped it, to get it to create suction, then you have this, it looks like a hand grenade. You pull the cap, squeeze it down, and then recap it. And then because I don't have it in a wound, it's going to pretty quickly reinflate. But when you have a wound in there, then there's going to be enough tension through the tissue pulling in on it with the suction, as well as whatever fluid might be getting hooked up by it, that it won't reinflate super quick. But this one will, because I don't have anything capping it. But if I like crimp the tubing, let's do it again. And so if I crimp the tubing, like there's actually something creating some tension and resistance, then the bulb will stay compressed. And over time, it will gradually pull that fluid out of there and start to reinflate. If it's in this position, it's not doing anything. So if it's full of blood, then usually what they'll do is just pull the cap off, squeeze the blood out into the toilet or some other container, flush it, and then re-squeeze it and reconnect it. So we always want to be aware if a patient has that. A little bigger drain. This one would be more for a wound that's draining a whole lot more. You can see it's actually got like some springs in there, but the idea is the same. You're just creating a little bit of a vacuum suction. So we pull the cap out, squeeze this down, push the cap back in to seal it, and then we've got a longer tubing here. Nice little musical thing there going on. It's kind of like bagpipes or something. But you don't usually hear that on a patient because the tube's in the wound. But I might have to do that again. That's kind of cool. Okay. What else do I have to show you? We have restraints. So this is one type of restraint that you might come across. Basically, you have a little Velcro strap. You're going to put the person's arm in there, secure that little piece of Velcro. Obviously, that's not going to stop the patient from ripping it open. So it also has this additional strap that's going to go through the little teeth. Feed it back through. If you've ever had a belt like this. And then you pull that tight so that way the patient can't get out, and then we can use the straps to tie that down onto the bed frame. So then when they try and pull their lines and tubes out, they can't move their arms. Sometimes they'll do the legs, but the arms are most common. Here is a Foley catheter. It's never been used. I didn't bring it home. I have had one in when I had my surgery, but that's the only time. So pretty big tubing. So yeah, that's going up your urethra, depending on which gender you are. It's the same size for both men and women. And then on the tip, this little end piece where it's kind of a little bit thicker, that's the balloon portion. And so when they're going to blow it up, they come into this part of the tubing right here and basically inject that air, and then it is able to puff that up. Sometimes Foley catheters will have a temperature probe that usually will like attach right there too. And that gives the nursing staff the instant readout of their temperature, because it's basically sampling their urine as it comes out of the body and gets the temperature probe that way. The probe might actually extend all the way out. It probably does. It probably goes into the tubing itself, would be my guess. Here's the little hook that you can use to hook it onto the walker, hook it onto, the IV pole somewhere down low. Again, we don't want to lift this high and cause that to backflow. Here's another little clip that's on the main tubing. So if you want to take up some slack so the patient's less likely to trip on it, then it works the same way as that JP drain tube, just a little clip. This one has a different type of drain device. With this type, you're going to squeeze that together, pull it out, and then dump it over. And then it has this metal locking pin right there too. So that would be the lock position. That would be the unlock position. Lock, unlock. And then when we're going to After we drain the bladder, drain the urine out of there, then we lock it and then clip it back in like that. Okay. Um, I'd been a PT for about a week before I got my first experience with this failing. I was doing exercises with a patient. I think she was a hip fracture patient, and this was on the edge of her bed. I'd raised the bed up so I wouldn't have to bend over. I was helping her with some exercises, and I must have pushed this little metal clip too hard, and it released. And so I'm standing there, and all of a sudden I'm like, I feel something wet on my leg, and it was just draining out of there and just had soaked my leg. So I got an issue. It's not fun. All right, almost out of goodies. This is, I'm gonna go ahead and open it. Just like I say, I've been using these bags for the last few years and I've never opened it. So this is an endotracheal tube. Um, and this is a little cuff that again you would inflate to keep it in place. But when somebody has to be intubated, this is the diameter tubing that's gonna go down their throat like that. And then that would be hooked up to the tubing for the ventilator itself. Then we've got a couple other ports to do different things, probably do meditations. One of these might be for temperature, I'm not sure. But then they would probably inflate this a little bit too. One of them is probably for inflating this. So once it's in there, we want to secure it and hold it steady so it's not as easy to pull it out. So this is the reason why we would put somebody in restraints. We don't want them to go, what is this thing? Yank it out. So definitely can damage the vocal cords when people have these in too long. A lot of times the patients that get them out, their voice is going to be super, super scratchy with that. So got some different size ones, but this is kind of the most impressive one because it's the biggest. All right, last thing, I think, is the chest tube. And so this tubing is essentially the size that would go into the person's rib cage. So they would end up having those, they make an incision in between the ribs, basically insert it in there, sutured in place, and then this piece would come out and would connect to a device like this. This one has fake blood in it. I grabbed it from nursing before I left the other day. And so this tube would be, this connection would be connected to the part that's coming out of the patient's body. And so this will usually sit on the ground. It has this base piece. Different ones have different types of ways that the base attaches. This one looks like it's kind of a permanent base that's in this position. Some of them will swivel on the bottom, so they can either be, so if you're gonna like hang it on the bed frame, you don't want this thing sticking out, you can kind of have that thing recessed. And then when you're gonna set it on the ground, in order to make it more stable and increase that base of support, then you'll flip it out into this position. This one, it's kind of permanently in there. You can probably snap it off. But the water part is what's going to help create the seal and replicate the pleura for that patient. And then this would be basically connecting fluid if the person had some bleeding or some extra fluid that had been drained out of the lung from when it was collapsed. If they had like a pleural effusion or something like that, it would collect in here. So you can get patients up and walk while they're hooked up to this. This is big. Again, you don't want to tip it over. You don't want to break the seal. It does have these little hooks. So these little hooks can be used on the front of the walker really well. And then you can just cruise along with this on them. Just watch out for the tubing and make sure that you don't let the patient trip over it or get tangled up in it as they go. So I think that's the end of show and tell. So we'll go back and kind of finish talking about some of the different conditions that you might see with that. So I'm going to stop my video so I can go back into hiding. And I'm going to share my screen. That's me. Hide that. All right. So people end up in ICU for all kinds of reasons, but usually they're in pretty bad shape. If they're going to be there, big strokes can put them in there, burns, heart attacks, renal failure, horrible infections, respiratory failure, major trauma, car wrecks, falls, things like that can put people in ICU. It really kind of depends on the facility that you're in. You know, a bigger trauma-based medical center, you're going to see anything under the sun. So like probably IHC in Murray or even Utah Valley, you probably see pretty extensive stuff. Probably at the U Hospital, I would guess you'd see pretty extensive stuff. Smaller community hospitals, Temp Regional, or some of the Mountain Star ones, the really bad stuff they probably send to other more capable institutions. So you may not see quite as many like trauma patients in some of those settings. But a lot of these other settings are the ICUs that I've worked in. I've seen some burn patients, plenty of stroke patients. One of the hospitals I worked at had a neuro ICU, had a pulmonary ICU, and then had more of a general ICU, so you could have different types of patients. And then that hospital had a whole separate cardiac unit where all the cardiac patients would go, and so they had their own ICU over there too. Smaller hospitals might just have one ICU that you'd have everybody in, and um, so respiratory distress, this is going to be kind of the primary reason that a lot of those COVID patients are in the hospital, that their lungs are failing them from the infection, damaging their alveolar walls and their lungs and making diffusion of oxygen and carbon dioxide really difficult. And that's why they end up getting put on ventilators sometimes. So once you get somebody on a vent, then you have to get them weaned off of it. And the quicker you can do that, the better, so they don't become dependent on it, and then it gets much harder to get them off of it. But there are patients that go home with a ventilator and live with it. Um, Sometimes they improve enough over time to get out of it and get the tracheostomy reversed, but usually not. Once they have it, they kind of keep it. Burn patients. There's Montgomery Burns. I don't know that he ever got burned. Um, so this gentleman, pretty badly burned, lots of his body. If we're doing our rule of nines, that's a lot. Probably at least 30% of his body damage there between all of that abdomen. Looks like most of that right arm. Who knows what else on the back, up onto his neck and throat, all that discoloration. So this guy's in for a long recovery, assuming he survives. Over on the right, these are the type of beds that you will very commonly see in ICUs. Most if patients are on a ventilator and they can't move themselves very well, if they've had a major stroke and they can't move themselves very well, they use mostly use what are called low air loss mattresses. And so it has this pump unit with this big tubing, and so it's like a big air mattress, but it has these like individual coils or cushion sections that can, as the patient's weight shifts around, will kind of deflate a little bit, so they're not having a firm pressure pushing up against them where more of their mass is kind of pushing down. And so they're called low air loss because they do kind of gradually lose air, but that's what allows the patient to be in more of a floaty state instead of just being on like a firmly inflated air mattress that maintains a constant pressure. It's much more adaptable to their body weight and the shifting of their body weight, and so it's able to accommodate that. Usually you won't even use sheets on these beds. It has this kind of nylon cover that goes over the top of it, and that's the sheet. Sometimes they'll put a draw sheet underneath it or a chuck in case the person soils themselves or something, but we don't make the bed up like we would a normal foam type mattress with these most often. That makes the bed really high. It also makes it really slippery. So it's a challenge. It's easy to get patients off of these beds, but it can be really hard to get them back on it, especially if they're shorter, because it's just hard to get a grip and they don't stick and they keep sliding. So if you ever get a chance to work with a patient on those, you'll see what I mean. Many times we'll deflate the bed to go from sit to stand or from stand to sit, get them repositioned, and then inflate it again, especially if they're not that tall. Strokes, another really common one. Depends on how severe the stroke is, but usually they're going to want to monitor their blood pressure pretty extensively, try and figure out what kind of medications they're on, trying to do a lot of things with that. And a new stroke patient can be somewhat unstable, so they want to be able to keep a close eye on that. If it's a more mild stroke, they may go to a different part of the hospital and they won't necessarily always go straight to the ICU. It kind of depends on the severity of it. One of the key things with stroke patients in particular is they're often going to be listed as NPO, meaning nothing by mouth is what that abbreviation stands for. So if they're concerned at all that that patient can't swallow effectively, they don't want to give them food or water and let them dump contents that should have gone into the esophagus into the trachea and get into the lungs. So um, these patients will beg and plead with you to give them a drink, to give them some ice, to do stuff, and if they're not allowed to have fluid, you cannot do that, no matter how much they plead, you have to say no. It's like being the tough parent. You can't buy the kid that candy at the checkout line just to make them quiet. And you can't give these patients water just to make them quiet. You just have to explain why they can't have water. Um, Sometimes they'll be allowed to have ice chips that they can kind of dissolve, that kind of crushed ice to kind of get their mouth wet, but they're usually not allowed to do like whole scale drinking because we just don't want that fluid to go into their lungs. Renal failure. Again, that's going to be our patient that needs dialysis. Some bigger hospitals will have a whole floor like just for dialysis patients. Um, and they have their own kind of little ICU setup where they can bring the patient from the normal room into the room where they have the dialysis machines, and they can monitor them more closely and do it that way. And then they'll just transfer them back to their regular room after the fact. Heart attacks, another really common one, and including people that have had surgeries, cardiac surgeries, in addition to heart attacks. Anybody that's had like bypass surgery, valve replacements, things like that will often end up in ICU for a period of time afterwards. And so this is a group of patients, including the stroke patients too, that will often be asked to be the first people to get these patients out of bed and be able to judge how the activity is affecting their systems and how they tolerate everything. So we need to be cautious with these patients. We need to know what they're doing. We need to be prepared for the unexpected, because you never know when people are kind of unstable when things might go a little haywire. Near drowning. I had a child when I did my first rotation was at a pediatric hospital, and I had a kid that had almost drowned that they were able to save, and he had some anoxia, some lack of oxygen to his brain, and some brain damage. And so that's the most common complication. But a near drowning patient could also certainly have a lot of pulmonary problems too. But usually you're looking at more of like a stroke or a traumatic brain injury type of recovery when the brain has lacked oxygen for a period of time. This lady in the little pink dress there looks like she's in a stander type of walker or type of wheelchair. So it's got power wheels on it. You can see these things blocking her knees, but she's upright, so she's not sitting, but this would allow her to move around. Looks like she's hooked up to a ventilator as well. And the way those will work is basically you have a mechanism that would basically have the person go from a 90-90 sitting position where their hips are bent 90, their knees are bent 90, and the chair kind of lifts up and kind of hinges and raises up, kind of pushes up on their bottom, supports them from the back on their back, and then having their knees blocked out with that bottom piece lets them be able to get upright and get the benefits of being upright and weight bearing. So that's kind of a standard type of power chair. Brain injuries and severe trauma would be other options. So those bad car wrecks, those industrial accidents, manufacturing accidents, farming accidents, any kind of bad fractures or lacerations that require multiple surgeries. So those patients can have a lot of external fixators for fractured limbs, things like that. And then you can certainly also get a lot of brain injury patients as well. And those would be the ones that would tend to have that intracranial pressure monitor. All right, I think that is it for the hospital and ICU settings. So hopefully you learned a bit and feel maybe a little bit better prepared if you end up having to do a clinical rotation in the hospital. I loved working in the hospital just because it was different every day, and it was pretty fast paced most of the time. And it's very much when you work in a good hospital, it's a great team vibe. It's a lot different than most therapy settings where you might have office manager, some PTs, some PTAs, and some aides, but you're all kind of doing the same type of work. Hospital setting, it's more kind of like a baseball team where everybody's got their own position. Each position is important in that patient's recovery. And so you can all work cooperatively together and do the best for the patients. So we'll talk more about that in some future classes. But until now, that's our last lecture of the semester for this class. So hope you enjoyed it. See you later.